Chronic myeloleukemia, CML, is a malignant hematopoietic stem cell disorder with an incidence of 1.622 cases per 100,000 adults in the worldwide and 0.36 to 0.55 cases in our nation. There is a strikingly elevated white blood cell count and markedly left-shifted myeloid series in peripheral blood and a low percentage of promyelocytes and blasts. Splenomegaly is the most consistent physical signs in CML. CML is characterized by a balanced genetic translocation. There's translocation between chromosome 9 and 22, involving a fusion of Abelson oncogene, that's Abel, from chromosome 9 with the breakpoint classed region, that's BCR gene, on the chromosome 22. This rearrangement is known as Philadelphia chromosome. The molecular consequence of this translocation is the generation of a BCR-Abel fusion oncogene, which in turn translates into a BCR-Abel oncoprotein. BCR-Abel is a constitutively active tyrosine kinase that promotes growth and replication through downstream pathways such as RAS, RAF, gene kinase, MYC, and STAT. CML can be divided into three phases. There's chronic phase, CP, accelerated phase, AP, and blood phase, BP. To make a diagnosis of CML, we have to consider the clinical manifestations, blood, and bone marrow examinations. About 30 to 50% of patients with CML diagnosed in the United States are asymptomatic, and the percentage may be lower in China. The disease is found on routine physical examination or blood tests. Common signs and symptoms of CML in CP result from anemia and splenomegaly. These include fatigue, weight loss, night sweats, low-grade fever, abdominal fullness. Splenomegaly is seen in about 90% CML, and hepatomegaly is seen in about 40 to 50% CML. The patients in accelerated phase may have fever in the absence of infection, get bone pain, and progressive splenomegaly. When in blood crisis phase, people will have bleeding and infection related to bone marrow failure. Male patients may have abnormal penile intraction. In peripheral blood, white blood count is elevated, and the myeloid series is left shifted with mature forms dominating. Basal failure and eosinophil failure may be present. The blasts are less than 2%. Progressive anemia and thrombocytopenia may be present at the late stages. The bone marrow is hypercellular with left-shifted myelopoiesis. Basal failure and eosinophil failure may be present. The blast is less than 10%. AAP is invariably low or negative. Megakaryocyte is normal or increased at diagnosis, decreased in late stages. The Philadelphia chromosome is usually present in 100% of metaphases, often as soil abnormalities. The translocation between chromosome 9 and 22 can be detected by routine cytogenetics or the pH-related fluorescence in situ hybridization, that's FISH, or by molecular studies. For the treatment of CML, we can do chemotherapy, HSCT, and molecular targeting therapy. Formerly used drugs for CML include hydroxyurea, busulfan, idarabine, alloxane, interferon, homohydrotonin. The landscape changed dramatically with the development of small molecule tyrosine kinase inhibitor, the TKIs, that was shown to potently interfere the interaction between the BCR-ABL protein and adenosine triphosphate, that's ATP, inhibit phosphorylation of tyrosine residues, and then prevent the activation of signal transduction pathways, blocking cellular proliferation of the malignant clone. This targeted approach was found to dramatically alter the natural history of the disease, improving 8-year overall survival from about 20% to 90%. The first generation of TKIs is imatinib. Imatinib, the routine dosage is 400 mg per day, has become the standard first-line therapy in new diagnosed patients with CML-CP. Sometimes patients will get resistant to imatinib. These patients who fail to achieve CHR at 3 months or fail to achieve MCYR at 6 months or CCYR at 12 months are considered to be imatinib resistant. Primary resistance is evident in about 15% to 25% of patients after 6 to 18 months imatinib therapy. For those who fail to imatinib treatment, we can choose the second generation of TKIs, including nilotinib and dasatinib. Although second generation TKIs are potent and specific BCR-ABL TKIs, they exhibit unique pharmacological profiles and response patterns relative to different patient characteristics, such as patients' comorbidities, disease stage, and BCR-ABL mutational status. All the TKIs have been approved by the U.S. Food and Drug Administration for the first-line treatment of patients with newly diagnosed CML in chronic phase, as CML-CP. Clinical trials with second-generation TKIs reported significantly deeper and faster responses. The impact on long-term survival remains to be determined. Patients who develop the T315I gatekeeper mutation display resistance to all currently available TKIs except ponatinib. Allogeneic transplantation remains an important therapeutic option for CML-CP who have failed at least 2 TKIs, and for all patients in advanced phase disease. For AP-CP phase CML patients, we can choose imatinib 600 to 800 mg per day, or second generation of TKI. Although HSCT and chemotherapy are also strategies for these patients. But the patients have poor drug tolerance and remission rate is low, and duration of remission is very short. That's all for today. Thank you.